Today, we are going to talk about mental health disorders and how it pertains to mental health nursing. To start off, mental health is the emotional and psychological well being of an individual that can interact with others, perceive their surroundings realistically, and use proper coping skills. It is a state of well being in which the individual realizes his or her own abilities and can use those abilities in day to day functioning. They can cope with normal life stressors by having an effective support system and effective coping skills. They can work productively and fruitfully, and they can also make a positive contribution to society. Wellness is another aspect of having good mental health, and that is being in good physical and mental health. If there's deficiencies in one aspect of wellness, then it can affect the other aspects of wellness as well, and we'll talk about that on the next slide. Wellness is also a purposeful process of human growth, integrating experiences and making meaningful connections, reflecting on your personally valued goals, and finding strength that results in well being and strong values. One major barrier to having strong wellness is things like poverty, unemployment, trauma, lack of education, and having a mental illness. So when we look at the 8 dimensions of wellness, there's 8 categories that determine how strong someone's physical or mental health is. So to start, we have our emotional wellness, and this is the ability to cope with stress. You can also have financial wellness. You can have social wellness, which is a sense of connection and having a strong support system. You can have spiritual wellness, which is the ability to find meaning and purpose in life. You can have occupational wellness, which is employment. And if it's not necessarily employment, it could be things like volunteering and some other way that someone is able to work. You can have physical wellness, intellectual wellness, which does not necessarily mean that the individual is of genius status or anything, but it's the ability to recognize your own creative abilities and finding ways to expand knowledge and skills. You also have environmental wellness, which is how pleasant your environment is. Do you live in a stimulating environment that has a lot of support, whether that be through resources or through social interactions? And those are the different dimensions of wellness. So if any of these are out of place, it can threaten wellness and it can contribute to the development of a mental disorder. They're also really important to consider when we treat mental disorders because it allows us for an avenue of intervention. So if you have a patient that comes in with depression, they're employed, they have a strong faith, they have a strong social environment, they're financially stable, but maybe their house recently burned down and they're living in a hotel. So then you know that environmentally, there are different interventions that we can do to try and strengthen that area of wellness to help support the emotional dimension or their ability to cope with their depression. So that really allows us to kind of find where we should focus our interventions. Also, individuals with mental health problems can have lower life expectancy rates up to a decade earlier than the general population. And we can kind of explain that through this dimensions of wellness, because if someone's disadvantaged socially, economically, or environmentally, they may have decreased access to healthcare, strong health information, and competent care. So it's really important as nurses that we consider these different dimensions of wellness when we're treating our patients and ensuring that we're really treating them holistically. A mental disorder is a clinically significant disturbance in cognition, emotion regulation, or behavior that reflects dysfunction in a psychological, biological, or developmental process. So some individuals may feel elements of mental disorders, but it's not necessarily considered an illness until it impairs with your ability to work, socialize, or function on day-to-day activities. So as you go through your psychiatric nursing course, you may find that a lot of the different diagnoses that are talked about may seem familiar. You may see the different symptoms and think, oh my goodness, I have all of those. But if you're able to function as a student, as someone who works, if you're able to take care of your ADLs, if you're able to function socially, you may have those symptoms, but it does not necessarily mean you have that disorder. Another aspect to being diagnosed with a mental disorder is that the symptoms have to be outside of your culturally defined limits. So, for some cultures, a certain symptom may be acceptable. For example, in Christianity, it's not uncommon for people to feel like God is speaking to them. However, if someone's of a different culture that they don't believe that and they feel that God's speaking to them, that may be an indication of a delusion or a hallucination. So we always want to look at the individual symptoms in the context of their cultural beliefs as well. Mental health disorders are diagnosed by the DSM-5, and it's a way to guide and identify treatment. It also helps us to identify syndromes. So a syndrome is a cluster of symptoms that can result from multiple causes, and it shows symptoms that are not fully understood or defined. And we see this a lot with mental health disorders because there's not necessarily a biological basis for all mental health disorders. So we may see a cluster of symptoms, but we might not necessarily understand why these symptoms occur. We do know that it can affect behavioral thought and feelings, and there's not necessarily, like I mentioned, an obvious underlying biological pathway. Mental illness is tracked by the CDC, and through this tracking, we know that mental health disorders are growing. We know that mental health disorders affect 1 in 5 individuals, and depression is expected to be the leading disease burden for healthcare by 2030. It's already one of the leading disease burdens in the United States and wealthier countries, but worldwide it is growing. And part of that can be due to a lot of things, especially now as we're in a pandemic and there's just a lot going on in the world. But we do know that things like social media has significantly increased rates of depression and anxiety. Substance abuse can significantly increase rates of mental disorders. So these are all different things that are tracked by the CDC. And the reason that the CDC tracks these things is so that we can get a better understanding of how these diseases develop and what the possible causes are, so that we can better understand the progression of illness. And once we understand the progression of illness and the possible causes, we can develop more effective treatments for our patients. So when we talk about epidemiology, there's a couple of different things that we cover. So rate is the number of cases in a population divided by the total population. So if your town has a population of 100, it's a very small town, and you have 5 people with depression, your rate is going to be 5%. Prevalence, on the other hand, is the total number of people who have that disorder within a certain population at a specific time. So this is a number. So where your rate was a percentage, your prevalence would be 5 because there's 5 people in that whole town that have depression. There's also incidence, which is the new cases in a population divided by the total population. So let's say that 4 of those 5 individuals have had depression for years, but you're just tracking the rates of depression for 2021. You have 1 new case out of that 5, so your incidence would actually be 1%. And then you have point prevalence, which is the portion of individuals in the population that have a disorder at a specific time. Usually, when we measure incidence and point prevalence, we measure it over a year's time. So when you're reading about depression or different symptoms and you have these terms, the rate of schizophrenia or the incidence of depression, you kind of have a reference point to why and how they get those measurements. So another thing that we need to talk about when we talk about mental illness is stigma. And stigma is a mark of shame, disgrace, or disapproval that results in the individual being shunned, rejected by others on the basis of having a mental illness, or treated poorly. So these individuals are treated like they are responsible for having their illness. And I'm sure that you guys have all heard the term stigma before because it's a really big problem, especially when we talk about mental health care. People with mental illness may be considered weak, immoral, or unfaithful. A lot of times it leads to discrimination against individuals with mental illness, and it also leads to a violation of their human rights. And the biggest barrier to fighting stigma is the understanding that people are not their disorder. And so a lot of times with stigma, we find that individuals feel that because everyone's telling them that having this disorder is their fault and having a mental illness is a bad thing, that individuals that have a mental illness may avoid going to their providers because they're worried that they're going to be diagnosed with a mental illness and that they're going to experience the stigma that we see so often in movies and on TV and in the news and all of that stuff. So what they do is they avoid going to the doctor because they want to avoid being labeled, and that's label avoidance. And that's a huge barrier to individuals with mental illness getting proper treatment. If they're afraid to go to the doctor because they're afraid of how they're going to be treated, they're not going to get the proper treatment that they need. There are two different types of stigma: public stigma and self stigma. And public stigma is when the individuals are publicly marked as having a mental illness, and therefore they have ABC negative connotations. So we see this a lot in television shows and on the media, although it is getting slightly better, but we still see it quite a bit. And it's the association that people with mental illness are violent or they're odd, which is not true. That's an example of stigma. A lot of times, TV shows, when they talk about individuals with mental illness in the healthcare fields, they're often stigmatized. They're often considered the difficult patients and things like that. So that's another way that television can stigmatize individuals with mental illness. And a lot of times, media, TV shows, if you look through different news articles about individuals with mental illness, you'll rarely see acknowledgement of recovery or successful treatment. So that promotes this stigma behavior as well. Public stigma often leads to ostracizing the individual, and the individual becomes very isolated. Self stigma is when the negative stereotypes are internalized by that individual. So it can lead to individuals having low self esteem, low self worth, and hopelessness. So, whereas public stigma says you have a mental illness because you're a bad person, or you have mental illness because you messed up, or you have a mental illness because you didn't exercise enough and you didn't eat healthy and you did drugs. All of those things is public stigma. Whereas self stigma is, oh my gosh, I can't have a fulfilling job because I have a mental illness. I can't run a marathon because I have a mental illness. I can't do this. I can't do that. That is examples of self stigma. So, how do we address stigma? First and foremost, we treat that person as a person because they are a person. We treat them as an individual and not as their disorder. And that can start with correcting stigmatizing language. So instead of saying, oh, I have a schizophrenic patient, you would say, I have a patient with schizophrenia. You also want to correct people when they're using words like psycho, crazy, bipolar to describe people that are being portrayed in a negative light. We can encourage people to spend time with a stigmatized group. Through spending time with someone that is often stigmatized, we can increase our awareness and empathy for that individual. It helps us to decrease our own judgments, and it helps to encourage positive coping and decrease self-stigma in the individual with a mental illness. So this is going to be a big focus for a lot of what you'll be doing in the healthcare field. It's the responsibility of nurses to correct these stigmatizing behaviors and to advocate for our patients. Another aspect to mental health care is the concept of recovery. So, recovery is based on guiding principles, which is on page 6 of your chapter. It's box 1.4. And basically, what these guiding principles are is a key for ensuring effective patient centered care. So, in recovery, we know that when patients have a patient centered and holistic care, they're more able to develop strong response to their treatments. So, the different guiding principles is that recovery emerges from hope, it is purpose driven. There's many different pathways to recovery. Just because a medication worked for one person doesn't mean that it's going to work for another person. Maybe someone's able to find recovery with coping skills where someone else may need ECT. So there's a lot of different pathways that we can approach recovery with. And that's one reason why I personally love mental health care. It's a very creative and flexible approach to treating individuals. It's not like if you have a patient that comes in with a UTI that you're just giving them an antibiotic and then they get better. If your patient comes in with anxiety, there's so many different things that you can do, and you can really spend time with that patient to better understand their needs and what's best going to help them. And that may be totally different than what you do the next day with another patient that has anxiety. Recovery is holistic. It's supported by having a strong social network, by having a lot of peers and allies. It can be culturally influenced. It addresses past traumas and helps that individual cope with that. It involves individual treatment, family treatment, and aspects of the community. And most importantly, it's based on respect for that patient. Mental illness and emotional disturbances are treatable, and recovery is the expectation for every patient that we treat. Recovery is also supported by 4 dimensions of support. So what this means is we want to make sure that that patient has strong health, and that's both physical and emotional. So we want to look at those 8 dimensions of wellness and treat any that are maybe not up to par. We want to make sure that they have a strong support in their home. So that means that they have a safe and stable place to live. We want to support them by making sure that they have purpose. If they have meaningful daily activities, independence, resources, income, they're going to reach recovery more easily. And then lastly, we want to make sure that they have strengthening relationships and a strong social support in their community. So the recovery framework is based on a continuum of care. So there's kind of 3 different levels of decision making when we approach patient care. The first model is the paternalistic model. And this model follows the belief that a clinician knows what's best and makes the choices for that patient. So the patient will do the best and they'll have the best treatment if their instructions are followed and if they follow what the clinician tells them is best. Then we have our informed choice model, which is the opposite end of the spectrum. And that's where the clinician shares evidence and offers opinions, offers options, but does not offer an opinion. So the patient has 100% choice in what they decide to do. In psychiatric nursing, we really aim for the middle ground in this shared decision-making model. So what shared decision-making is when the clinician shares evidence and offers opinions, but the patient is supported in considering their options and making any choice that they feel is best for them. So the shared decision-making model is the basis for your patient-centered care. The benefit of using the shared decision-making model is we often see that it helps to best reduce symptoms. It improves self-esteem in the patients. It increases their satisfaction in the services provided. It helps to improve medication compliance and treatment compliance. It improves patient knowledge as well as decision-making abilities. And it allows the patient to be more interactive in their care. As I'm sure you guys all remember from your previous nursing classes, patient-centered care is fundamental. We need to involve the patient in everything we do. We need to encourage the patient to make meaningful decisions for themselves. We need to make sure that they're educated and informed so that they can make the best decisions for themselves. And patient-centered care is really, really focused on having a strong patient-nurse relationship. Because when we have that strong patient-nurse relationship, we can better empower our patients. And empowerment is supporting an individual or a community to take control of their own healthcare needs and encourage them to use their own healthy behaviors, positive coping skills to improve their mental wellness, helping them to self-manage their illness and their well-being. Empowerment, again, helps improve decision-making, compliance with treatment, and the health of the patient. Another key aspect to the recovery framework is that the individual has meaningful employment. And what this means is that they have something that gives them purpose, can help improve their mental health, access to care, and overall, when we have a lot of people that have meaningful employment, it can reduce the cost of mental health care by reducing the need, but also improving access to mental health care, early intervention, and appropriate healthcare insurance and things like that. Employment can very often be difficult for individuals with severe mental health symptoms because sometimes the psychological symptoms can lead to physical impairment, or it can also lead to um, inability to work certain jobs. So we really want to be aware of how mental health symptoms can impair someone's ability to have meaningful employment. It can also lead to interpersonal conflict. It can lead to worsening of their symptoms and side effects. If someone has poor support or poor resources or academic underachievement or poor coping abilities, it increases their risk of being unemployed related to the symptoms of their mental illness. So, kind of with that, we really want to make sure that we're addressing any of these barriers. Um, Poverty is a huge barrier when it comes to individuals with mental illness. And I'm sure that you can imagine that. If you think about your 8 dimensions of wellness, if you're living in poverty, you may not have the ability to have a strong environmental wellness. You may not have a strong ability to have a strong social wellness. You may have decreased access to healthy food, so you may have physical ailments. So you can imagine how poverty really impacts a lot of the different dimensions of wellness and how that can lead to mental illness. Individuals that live in poverty often report that they feel unable to fully participate in society. They have difficulty meeting their basic needs. They may have a lack of permanent or safe housing. They may lack transportation and access to transportation services. So if they can't have transportation, they can't get to a job, they can't get to their healthcare appointments. They may have difficulty paying for medications or healthcare, so they may not take any medications or follow up with the advice or the plan that they form with a provider. There is different levels of assistance that individuals can have to help fight poverty, and that's through government supplementation, social security, disability insurance, and things like that. So as nurses, we can always refer our patients living in poverty to different support systems and support groups. Homelessness is another huge barrier. So it's really important that our patients have safe, affordable, and permanent housing because that adds stability. Going back to that dimensions of wellness. If our patient has that safe, affordable, and permanent housing, they're going to have better access to environmental wellness, social wellness, and all those different things. So, we really want to. Another reason that housing is really important is that it can lead to easy access to benefits and services. So, if someone has safe, affordable, permanent housing, they're going to possibly have better access to Wi Fi, to food, to transportation, things like that. With homelessness, individuals have a lack of that. They have a lack of fixed, regular, adequate nighttime residence. There are two different types of homelessness. There's sheltered and unsheltered. So sheltered homelessness is when they are able to stay at either a shelter or a hotel, or maybe they stay with a neighbor or a family's house, or maybe they surf from couch to couch. So they technically do not have a fixed, regular, and adequate nighttime residence, but they at least have a roof over their head each night. Unsheltered is when the individual doesn't have that. They're often spending the nights on the streets and in the open air, or possibly in their car. They may sleep at parks, abandoned buildings, tents, or a bus or train station. We know that homelessness increases stress and unhealthy behaviors. It can lead to substance abuse. It can also lead to increased exposure to crime and trauma. It can lead to frequent or fear of incarceration. Um, so there's a lot of efforts to try and reduce homelessness in the mental health population and homelessness in general. So one way that we do this is through Housing First, and this is a homeless assistance program, and it's based on Maslow's hierarchy of needs. So we know that people need food and safety and security before they can work on bettering their self-esteem, their productivity, and their recovery. So there's different levels of housing that we can refer a patient to. Short-term housing is a transitional housing, like a halfway house, a residence, or a group home. Intermediate term housing is a group home, and long-term housing is things that are more stable and permanent. So that would be things like maybe a state hospital or Section 8 housing. So if you guys are unaware, Section 8 housing is often reduced housing in a nicer area with affordable healthcare, because we know from experienced that when individuals are in an area where they feel important, aesthetically pleasing, where they feel comfortable and safe, they're going to be able to work on themselves more. They're going to be able to cope more effectively. Um, a lot of housing programs also provide other services like medication management, um, goal setting and groups, social skills building, assistance with financial budgeting, and vocational training. So that's really important. In order to utilize things like Housing First, we do something called homeless rehabilitation. The first stage of homeless rehabilitation is outreach and engagement. So we recognize the needs of that specific homeless individual. Step two is in transitioning them into intensive care. So this would be referring them to that short-term transitional housing or different programs. Stage three is intensive treatment. So this is where the patient manages and makes their own goals and gains access to housing and medical care. We also can do preventative skills training at this point. Stage four is transitioning from an intensive care to an ongoing rehabilitation, which is usually a 1 to 2 year program of supportive housing. And it's usually more permanently transitioned into affordable housing so that we can promote independent lifestyles. And then stage five is ongoing rehabilitation. Another barrier to the recovery framework is stigma, which we talked about earlier. But one thing I want to add is there's a term called stigma resilience. And this is when the individual has the capacity to withstand or recover from challenges that threaten their stability, viability, and development. So it goes against the effects of stigma. And then lastly, having lack of services. So a lot of mental health care is severely underfunded, which I'm sure you guys all know. You'll see when you go to your clinical rotations that the units may seem inadequate or outdated. Some of the treatments may be inadequate or outdated. A lot of individuals have poor access to mental health care. 56% of adults with a mental health disorder are unable to get treatment in the United States. The typical nurse to patient ratio on an inpatient psychiatric unit is 1 to 8 to 1 to 13 patients for each nurse. And so we know that a lot of nurses that work in mental health care or a lot of providers in mental health care are often burnt out due to short staffing. And so that can lead to increased stigma or ineffective care for our patients that have a mental illness. And a lot of times there's a disconnect between a primary care provider and a mental health care provider. So it's really important that as nurses, we help to transition the patient's care and coordinate their care properly. It's going to be really important that we fight stigma and improve funding for mental health care, and that we also reduce the stigma in working with mental health patients so that we can improve the patient to nurse ratios and reduce rates of burnout related to short staffing. Another way that we can do this is through peer support. So peer support is a program where an individual is paired up with someone that has been successful in recovery and experienced similar situations so that they can help encourage that patient to advocate for themselves and have the health care that they need. So yeah, basically, as a summary, the key to fighting barriers and helping our patients be successful in recovery is to advocate for our patients and to help them overcome and address any barriers that they have. So moving on, another key aspect to recovery-oriented and patient-centered care is providing cultural and spiritual humility. Some books call it competence. Some are saying that competency can be a stigmatizing thing. So you may hear cultural humility, you may hear cultural competency, just to kind of clarify that. So what is culture? Culture is a way of life, and it's the way that people identify or associate with one another on the basis of having a common purpose, need, similarity, and background, as well as the totality of learned, socially transmitted beliefs, values, and behaviors that emerge from interactions with other members of your culture. Culture is dynamic and constantly changing. And there's two different key terms that we talk about when we talk about culture. The first one is cultural identity. And cultural identity is a set of cultural beliefs that one looks to for the standards of their own behavior. And then there's acculturalization. And this is a socialization process in which minority groups learn and adopt selective aspects of the dominant culture. It can change someone's cultural identity. It can contribute to subcultures within one culture. And it also is kind of the basis for the mixing pot identity that a lot of people associate America with. Um, because of things like cultural identity and acculturalization, it is really, really important that we ask our patients specifically what they believe and what cultural needs that they have in order to be best culturally competent or practice cultural humility the best. So there are two aspects to practicing cultural humility. One is linguistic competency, and this is the capacity to communicate effectively and convey information that is easily understood by diverse audiences. So when we think of linguistic competency, we're asking ourselves two questions. Can the patient understand what I'm saying to them? And can the patient communicate back to me what they feel they need to communicate? A lot of people look at linguistic competency and think, oh, language barriers. Yeah, we have to make sure that we're speaking the same language so that the patient can hear what we're saying and that they can communicate back. And that is true. However, linguistic competency is much broader than that as well. It could be things like having different systems of grammar and syntax. It could be the appropriateness of topics. It could be the ability to take turns in talking, the understanding of symbolisms and metaphors. It could be based on nonverbal communication and other hidden rules of interaction based on different cultures. So not only is that the ability to speak the same language, but it's can the patient hear you? It could be related to deafness. It could be related to maybe the patient's having psychosis and they're hearing voices. So that may impair their ability to hear and understand you. Maybe the patient is having racing thoughts, so they can't focus on what you're saying. All of those things are part of linguistic competency. So it's really important as nurses that we implement proper interventions to ensure that we're able to effectively communicate with our patients and our patients are effectively able to communicate with us. Linguistic competency is much more difficult in mental health care than it would be in a medical setting. And the reason for that is because patients that are receiving mental health treatment spend a lot more time with meaningful conversations. They see their psychiatrist, they see their social worker, which we also have commonly in the medical setting as well. The patient has to see different providers and everything. But in addition to that, individuals that are receiving mental health care also have to be able to attend multiple groups throughout the day, and they need to understand what's going on in those groups. So most of our patients would need some form of translator, especially if it's based on a language barrier or deafness. So translators are very expensive for the hospitals, and hospitals a lot of times don't want to utilize them because they are very expensive. So what they'll do is a lot of units have those iPads or translation phones, and that kind of helps to overcome that linguistic barrier. However, in mental health care, things like an iPad or those types of telephones could be considered contraband. So we can't necessarily use them, and we mostly have to rely on having an in-person translator. Again, because they're so expensive, it's hard to get a translator that's going to be available during all the time that the patient needs. So think about that when you're working with a patient that may have a language barrier. The other aspect to cultural competency is cultural humility. And this is the understanding and appreciation of cultural differences and the ability to interact effectively with an individual of another culture using academic and interpersonal skills that are respectful and responsive to that individual's healthcare beliefs, their care practices, and their cultural and linguistic needs. So in order to practice proper cultural humility, we have to value that individual's cultural beliefs. We have to bridge any language barriers. We have to accommodate any of their spiritual or nutritious needs. And we have to consider their health beliefs when providing care. Again, this could be difficult in mental health care as well. And the main barrier to providing cultural humility is lack of knowledge on that culture. So, as I mentioned again, it's very, very, very important that we ask that patient specifically, what are your cultural needs and your cultural beliefs? A lot of patients may be incompetent mentally, meaning that they, um, based on the severity of their symptoms, they're unable to effectively explain their cultural beliefs or their cultural needs. And that can be difficult to address any cultural needs that they have if the severity of their symptoms is preventing them from effectively communicating what those needs are. Sometimes practicing cultural humility can alter the milieu for other patients as well, and it can also present a safety risk. So, for example, a patient may be Catholic and they may have to say the rosary so often. Well, the rosary is a string of beads, and that string of beads can be used to wrap around someone's neck. So we would consider that a safety risk for our patients that have suicidal behaviors. Um, so it's really important as nurses that we look at their spiritual needs and we find a way to allow them to um, have what they need without presenting a safety risk. So for that rosary, you could have the patient say the rosary with someone supervising in the room. You could have them use a paper rosary or things like that. There's a lot of other cultural related things that we talk about in mental health care. And the first one is cultural bound syndromes. And what these are syndromes that only occur within a specific culture. It can be co-occurring symptoms that occur in one culture, or it can occur in multiple cultures as well. But regardless, it leads to a cultural idiom of distress and cultural explanations. So remember back to the original slide that mental illness occurs when it is expected and outside of normally culturally defined limits. So when we look at cultural idioms of distress, even though they still occur within a culture, it does not necessarily mean that it is expected within their culture. So the first one is the cultural idiom of distress, and this is suffering characteristics within a cultural group. So for example, I'm going to say this wrong, but adequate de nevrosius is something that is often experienced in certain populations, and that's when they experience a headache, irritability, nervousness, insomnia, difficulty concentrating when experiencing distress. And this is often experienced in Hispanic or Western Hemisphere cultures. Cultural explanations is how a culture perceives the cause for those symptoms. So, for example, susto is a Central and South American belief that the soul leaves your body when you're frightened, which can cause appetite disturbances, sleep problems, and low self worth. Um, Cultural idioms of distress and cultural explanations can lead to differences in treatment, and it may allow us to, or it may cause us to treat symptomatically instead of mentally. So, for example, if you have someone that comes in with an appetite disturbance, sleep problems, and low self worth, that may be symptoms of depression. But because the belief is that their soul has left the body, the treatment may be that they have to go to practice their religious beliefs instead of taking an antidepressant. Or with the adequate de nevrosius, or however that's pronounced, if they have a headache, again, all of headache, irritability, nervousness, insomnia, these can all be symptoms of depression as well. But we may give them medications for their headaches, and then the depression is left untreated, and they may not see an improvement in symptoms. So there's a lot of debate between whether or not treating symptoms over treating the disorder is effective treatment, and how to practice cultural competency while still providing those effective treatments. Um, we also know that racially and ethnically diverse groups are less likely to receive mental health care because they have decreased access to health care. It could also be based on their mental health care beliefs. They may avoid health care due to fear from language or cultural barriers, or they may have decreased or poor experiences with healthcare. And all of these can lead to poor quality of care. So individuals that are receiving poor quality of care and have poor beliefs on the healthcare system are less likely to comply with treatment if that treatment is not aligned with their cultural or religious beliefs and practices as well. So the Boyd Essentials of Psychiatric Nursing does give a lot of examples of common cultural beliefs on mental illnesses based on the Hispanic Americans, African Americans, Asian Americans, Native Americans, rural cultures, and women of minorities. So it may be important to take a look at that and kind of get an understanding for some common cultural beliefs or barriers for different ethnic and racial groups. Also, it's important to remember that there are cultural differences between urban and rural societies, as well as with women versus men. So even though someone may be of a majority culture, they still could have different cultural beliefs based on their gender, based on where they've been raised and where they live and things like that. So we want to consider that as well in providing culturally competent care. Spirituality and religion are also a major component of mental health care and mental illness as well. So spirituality is a dynamic, conscious process characterized by transcendence and introspection. It develops over time and includes 5 attributes, meaning the person has meaning, a sense of purpose, and a sense of purpose for life and for existence. They have beliefs, which are coping mechanisms that elicit hope. They have connection to higher power, and that can provide support during times of crisis. They have self-transcendence, where they can appreciate a dimension beyond their own self. They have value, which helps drive what's important to that individual. Spirituality is different than religion. Religion is the actual participation with a community of people who gather around one common form of worship, and that allows them to express their spirituality through religious beliefs. There is a table 2.1 on page 12 and 13 of the Boyd Essentials of Psychiatric Nursing, 2nd edition, that explains different religious beliefs and outlines how that can impact healthcare. We really want to consider spirituality when we provide mental health care treatment because patients really find it very beneficial. So it is beneficial to do a spiritual assessment and interventions, as it seems to be very effective in helping them develop a perception of well-being, health, and purpose. Again, there are certain safety considerations when we look at spirituality. We want to look and see if their religious practices are really a coping skill or if it can be hindering to care. Sometimes when their religious practices starts to interfere with their ability to function properly, we would call that a religious preoccupation or a religious delusion. So for example, I had a patient one time that was religiously preoccupied, and this patient felt the need to pray incessantly. So this patient was praying at every hour of the day to the point that they weren't eating, they weren't sleeping. The patient wasn't getting up to use the bathroom, so they were wetting themselves and experiencing incontinence because they could not stop praying. So at that point, it was interfering with their ability to attend to their ADLs and attend to their basic human needs. So that would be a preoccupation versus someone that can pray and find comfort in that. So it's really important that we look at that when we're providing treatment as well. Another thing that I want to mention too is there is something called a religious delusion. And this is when someone has a delusion that is religious in content. So a lot of patients may think that they are God, or they may think that they're Jesus or some other religious deity. They may also have fixed beliefs that maybe they were abducted by aliens, or that God sent them here to do a specific task and things. And so you really want to make sure that you're doing a thorough assessment whenever our patients are expressing any of those thoughts and beliefs, because we really want to make sure that it's outside of their cultural beliefs and their cultural expectations before we go right in saying that they have a religious delusion and providing treatment for that. So next we're going to talk about patient rights and legal issues. So the first thing that I want to talk about is how we can protect patients' rights. Patients' rights are largely based on self-determination, and that's the internal motivation to make choices on your own personal goals without the pressure of rewarding or pleasing others. So this is the basis for autonomy, and it's a process of engaging in activities that are interesting, challenging, pleasing, exciting, fun, and elicits positive feelings for that patient. So it's promoting independence and avoiding dependence. It allows our patients to make their own choices on their healthcare related behaviors. So they do have the right to refuse treatment. They do have the right to gain a second opinion, and they do have the right to choose alternative care. This can be very difficult in mental health care because some of our psychiatric disorders and side effects of medications can impair the patient's insight, judgment, and ability to comprehend situations, treatments, and alternatives. So, if you have a patient that is psychotic, they may refuse medications without the full understanding of that medication or the need for treatment, which is not informed consent. Um, so it's really important that we give our patients as much autonomy as possible, but also acknowledging where they're at and the ability to make decisions for themselves. So there is an act called the Self-Determination Act, and that states that a patient must be informed of their right to make healthcare decisions at the time of admission. So they must be offered and provided information on advanced care documents like an advance directive, and they must be asked at admission if they have an advanced care document to be put on file. So if you ever do an assessment, and this is the case for both mental health patients as well as patients in a medical setting, at admission, you always ask them if they have an advance directive. So an advance directive is a legal document that directs the patient's wishes for care. It can be a living will. It can also provide for a power of attorney, which is a healthcare proxy that's designated to make decisions for that patient if the patient's unable to do so. So someone may have a power of attorney, but they could still hold the right to make their own healthcare decisions. So for example, someone may know that they're getting older, they may make their child their power of attorney just in case anything happens. So that patient can still make decisions for themselves, but then if they become unconscious or if they develop dementia and aren't considered competent, then their power of attorney would step in and make those decisions for them. There is a specific type of advance directive for psychiatric patients, and it's called a psychiatric advance directive. In order to make a psychiatric advance directive, you do have to have two witnesses. This is kind of a newer concept, so you might not see this that often in healthcare, but it states what the patient would prefer or be comfortable with when they are competent. So they make this decision when they're of sound mind, so that when they have an episode of psychiatric symptoms that can impair their decision-making abilities, we can kind of know what care they're comfortable with and we can consider their wishes. This does improve patient-centered care and it can improve care outcomes and compliance, but a physician can override these wishes, which is opposite of a medical advance directive, if they feel that the patient is not, if those decisions are not in the patient's best interest. In order to override it, though, the patient must be informed properly and they do have to go to court to decide if the physician is able to override those wishes. Another thing that we have is the Bill of Rights for Mental Health, and this is a document that outlines extra rights for individuals that have a mental illness since they are considered a vulnerable population. There's also the Americans with Disability Act and Job Discrimination, and this act includes individuals with a mental illness as having a disability. So it gives them legal protection against discrimination in the workplace, discrimination in housing, discrimination in public programs and transportation, and discrimination in telecommunications. It does state that individuals have to have reasonable accommodations provided for them. And so again, that includes accommodations for any mental illness symptoms that they may have. And then we have protection and advocacy systems. So these are systems that help a patient that has a mental health care receive the care, benefits, and access to treatment that they need. There's internal and external systems. So the internal rights protection system are ways that a hospital or a healthcare system advocates for their patients, and protects their patients' rights. So it's an individual built into the system that evaluates the patient's needs and the patient's rights and makes sure that they're being attended to. So in the psychiatric setting, you have an internal rights officer, and that individual comes and investigates any complaints against or violations against the patient's rights. There's also external advocacy systems that are financially and administratively independent from the agencies or mental health care settings that they negotiate and recommend changes to. They don't have a lot of official legal authority, but they do have a lot of influence. So these external advocacy systems are going to be really beneficial in helping fight stigma and building resources for our patients with a mental illness. Patients are also protected by accreditation systems. So I'm sure that you guys have heard of like CMS or JCO. So what these do is they regulate hospital practices to ensure that the patients are receiving safe and effective care. And then patients are also protected by use of our own nursing values. So we'll talk about this a little bit more in another lecture, but it's important that we also talk about how to protect a patient's privacy and confidentiality. So privacy is protecting a patient's personal life that is not governed by society and government intrusion. So this is things like covering them up when they're bathing. If they are, changing in their room and the door's open, it's things like shutting that door. Confidentiality is non-disclosure of information on the patient's medical care. So you can violate privacy without violating confidentiality. If you violate confidentiality, however, you are also violating that patient's privacy. So confidentiality is regulated by HIPAA, and confidentiality is especially monitored for patients of the psychiatric population because they are a vulnerable population and there is a lot of stigma and consequences if their confidential information is released. The only time that you can breach confidentiality for a psychiatric patient is if the patient informs you that they have harmed someone or that they are about to harm or injure someone. And this needs to be reported to the authorities, and it is reported under the duty to warn mandate. And based on this mandate, we do have to inform the foreseeable victim of the patient's plan. Another way that we could protect patients is by providing least restrictive care in the least restrictive environment. You guys may be familiar with this concept, but basically it means that we have to try least invasive options first. And it's also very important that we thoroughly document that we did do those least invasive options first, or that the patient wasn't appropriate for the lesser restriction, because it can cause psychological harm and physical injury to a patient if we go straight to a more restrictive setting or a more restrictive intervention. And so we need to justify why we did that. So when we look at least restrictive care, we always start with self-care. So that's things like our coping skills, changing our eating habits, our exercise habits, our sleep habits. If that is not effective in treating the patient's symptoms, we can increase them to counseling or an outpatient setting. If that doesn't work, we can refer them to medical treatment. If that doesn't work and the patient is a threat for their own safety or someone else's safety, we can provide them with chemical restraints. So a chemical restraint is the use of medication to restrict the patient's behavior or freedom of movement through medications that are either sedating or restricting, and it is often at a higher dose than what you would see for typical psychiatric treatment. If that is not effective in keeping the patient safe based on their symptoms, we can put them in seclusion. So seclusion is an involuntary confinement of a person in a room or an area where that person is physically prevented from leaving. So this is not telling a patient to go to their room to calm down. This is actually putting the patient in a room and locking the door so that the patient cannot get out. If seclusion is not effective in keeping that patient safe, we can put them in restraints, which is a manual method to impose or reduce the patient's ability to move. So the restraints can be soft or leather, and it can be 4 or 5 point. So 4 point would be your wrist and your ankles, where 5 point would be your wrist, your ankles, and a lap belt. If a patient is in seclusion, or restraints, they are with a staff member the entire time. So the staff member has to be observing them, documenting, doing frequent assessments, which we'll talk about at another time as well. When a patient's in seclusion, it is a safe room with no furniture. It may have a mattress, it may have padded walls, and the patients also need to have access to go to the bathroom and have proper nutrition as well. So restraints and or seclusion can never be used out of convenience. It must be a last resort. It needs to be used for the minimal amount of time necessary. We have to use the fewest number of restraint points possible to keep that patient safe. And restraint and seclusion is not necessarily effective. It can cause trauma, it can cause injury, it can prolong the patient's care, it can extend their treatment time and increase the risk for readmission. So it's really important that we really, really, really only use restraints and seclusion when absolutely necessary to keep that patient safe in the moment when there's no other way to keep them safe. So when we talk about least restrictive care, we also talk about least restrictive setting. So again, the least restrictive setting is just self-care, doing whatever you can on your own. The next level of setting is outpatient care. So this is things like counseling, self-help and support groups, and telemedicine. If that's not effective in treating the patient's symptoms, they can be referred to a partial program. So in a partial program, they attend groups and they attend programming during the day, but they're able to return home at night. So they receive very similar treatment to a patient that's going to be in an inpatient setting. They still see a psychiatrist, a social worker, a case manager, they have medication management, they attend groups, but they're safe to return home at night, meaning they're not going to go home and attempt suicide. They're not going to go home and be unable to take care of themselves. If for some reason they are deemed unsafe to take care of themselves at home, then the next level of setting is an inpatient setting. And this is more commonly what students will experience during their clinical rotation for their psychiatric nursing courses. When you are inpatient, there's two different ways that you can be admitted. The first one is voluntarily, meaning that the patient chooses to be admitted to the hospital. It is still a lockdown unit, so they cannot leave whenever they want. There's not a thing as leaving against medical advice in a psychiatric setting. But if they do feel that their symptoms have improved and they're ready to be discharged and they don't have a discharge plan yet, they can sign a 3-day letter. And this 3-day letter gives the provider 3 business days to evaluate that patient and determine if their symptoms have resolved enough to the point that they're able to be discharged. If they're not, then the provider can change them to involuntary. So involuntary is the other way that an individual can be admitted. In order to be involuntarily admitted to an inpatient setting, the patient needs to be mentally disordered, dangerous to themselves or others, and unable to provide for their basic needs. So what they do is someone fills out a petition form. The petition form is then brought to the hospital with the patient where they're evaluated to rule out any medical causes for their symptoms, and then they're seen by a provider which fills out a clinical certificate. Then, if the provider agrees that the patient is either mentally disordered, dangerous to themselves or others, or unable to provide their basic needs, then they can bring them up to the inpatient setting where they're evaluated by a different psychiatrist. And this psychiatrist also has to evaluate them and fill out a clinical certificate. This has to happen within 24 hours of the first clinical certificate. So the patients have 48 to 92 hours that they can be admitted involuntarily on a short-term emergency stay. During this time, they have to be set up for a mental health probate court. Once they're set up for probate court, they can be held involuntarily until they get that court ruling on if they need a court order for treatment. So in Michigan, it's usually set up about 2 weeks after admission. And what the patient does is they go to this mental health probate court, and the provider and the patient get the opportunity to discuss whether or not the patient can reasonably make healthcare decisions for themselves to effectively comply with treatment. If the judge deems that the patient is unable to care for themselves properly, they'll put them on a court order for treatment, which has differing lengths. But basically, that court order for treatment says, yes, legally, we can hold them in the hospital for this many days against their will, and they have to comply with treatment this many days once they're discharged. If the patient does not comply with that treatment, they are brought back into an inpatient setting on an existing order. And so, even though we can only hold a patient legally for up to 92 hours against their will, if they have that court date set up with the anticipation of being put on a court order for treatment, we can actually have them much longer in the hospital. Um, there are some conflict in understanding between the ER and the psychiatric inpatient units on that. So, you will get a lot of patients that are told in the ER, oh, you just have to go up to the hospital and spend the night there and then they'll release you tomorrow. That is not true, and that is not the case, and that almost never happens. So then the patients come up to the unit, they expect to be released the next day, and then they become very agitated. So it's really important that nurses are advocating for their patients and providing proper education. There is another law here in Michigan that we follow, and that's called Kevin's Law. And Kevin's Law states that someone could be admitted to an inpatient treatment facility even if they don't quite meet the admission criteria, but there's reason to believe that they will decompensate quickly enough to the point of requiring treatment. And so that's kind of like a preemptive, hey, we're anticipating that this person's going to have very severe symptoms very soon, so let's get them hospitalized, early treatment, so that the symptoms do not become as severe and interfere with the patient's life as much. Another aspect to mental health care that you can receive treatment in is through support groups, rehabilitation centers, nursing homes, and prisons and forensic centers, which we're going to talk about next. So the criminal judicial process in forensic mental health care is based on forensics. So forensics is a legal proceeding and mandated treatment of a person with a mental illness. It is often at a forensic centers. So they opened up forensic centers after they closed state hospitals because a lot of patients were relocated or ended up in county jails and correctional facilities. So we would send a patient to a forensic center if we're trying to determine if they are competent to stand trial or if they have been deemed not guilty by reason of insanity and have a sentence that needs to be a sentence that they have to fill in a medical setting. So competency is the degree to which a patient can understand and appreciate information given to them during the consent process. So this is based on different things. One, how well can they process information at a specific time? Two, how competent or how able are they to make decisions? Someone who is incompetent is unable to understand and appreciate information that's given to them during the consent process. If someone is deemed incompetent, legally we can force treatment on them, which we do try to avoid because it does resist self-determination and limits successive outcomes. But if it is necessary, we legally are able to if they're deemed incompetent. So to determine competency, the patient must meet 4 criteria. The first criteria is that they can communicate their choices. The second criteria is that they can understand relevant information. The third criteria is that they can appreciate the situation and its consequences. The fourth being that they can use a logical thought process to compare the risks and benefit of their treatment. A patient must be determined competent in order to give informed consent. If a patient commits a crime, we want to determine their fitness to stand trial. So someone who commits a crime and has a mental illness at the same time that that crime is committed is evaluated for fitness. And their fitness is the ability to consult with a lawyer with a degree of rational understanding of the facts of the crime and the legal proceedings. So they must be competent in order to stand trial. If they are unable to do that, they are deemed unfit to stand trial and they're hospitalized at a forensic center to receive psychiatric treatment. They're reevaluated within 1 year to see if they have gained fitness to stand trial. And if they have, then they go forward to trial. If not, they continue with treatment. Once they are determined fit to stand trial, they go through the court proceedings. There is one ruling that a patient can get if they have a mental illness and have committed a crime. Um, so they can be guilty but mentally ill, meaning that they understood what they were doing, they still committed the crime, and while they are mentally ill, the mental illness did not impact their decision or ability to commit the crime. The other one is not guilty by reason of insanity. So this means that the patient was unable to distinguish right from wrong due to their mental illness and are involuntarily admitted to a secured psychiatric setting for their sentence. So if they are not guilty by reason of insanity, they still committed the crime, but we are not able to say that they should be held accountable because they didn't understand what they were doing. So like I said earlier, they will be sent to the forensic center to um, fill out their sentencing. So they still get the same sentence that they would if they were determined guilty but mentally ill. But instead of filling it in a prison, they would fill it in a forensic center where they receive proper treatment. Getting not guilty by reason of insanity is very, very, very rare. Less than 1% of the cases that attempt are actually granted it. Two individuals that tried to get this during their proceedings but were denied is Jeffrey Dahmer and John Wayne Gacy. However, a few people that did receive not guilty by reason of insanity was Ed Gein. So I don't know if you guys know him, but he was the inspiration for the Texas Chainsaw Massacre, Psycho, and Silence of the Lambs. And he used to murder women and then wear their skin. And he ended up being granted not guilty by reason of insanity and spent the rest of his life in a psychiatric facility. Steven Steinberg is another individual that was awarded it. He basically stabbed his wife 26 times using a kitchen knife. And the reason that he was awarded not guilty by reason of insanity is because they proved that he was actually sleeping while he did it. Another thing that we talk about when we talk about the criminal judicial process in forensic mental health care is probation. So probation is something that's given for minor offenses as an alternative for jail, as long as care at a treatment facility can be arranged. So sometimes if someone is given probation, they may have to seek mental health treatment as well. And lastly, I just want to talk about legality in nurses. So this basically covers different ways that nurses may be held legally accountable for actions that they did towards their patients. So the first one is assault. Assault is the threat of unlawful force to inflict bodily injury upon another. And I know that it sounds absolutely crazy to think that a nurse may assault a patient, but it does happen sometimes, especially in more stressful settings like a mental health care setting. This is technically different than if a nurse uses self-defense if a patient is trying to assault them. And there are different laws in the United States. It varies state by state on whether a nurse can be held accountable if they injure a patient in self-defense. Unfortunately, here in the state of Michigan, if a patient attacks you or assaults you and you try and defend yourself and injure the patient in that defense, you are still held accountable and you do not have protection that you would have in other states like New York. So it's really important that nurses also advocate for their own safety and that you advocate for improved laws and protections against nurses. Medical battery is another legal term, and this is the intentional and unauthorized harmful or offensive contact that occurs when treating a patient without consent. Another aspect is negligence, and this is a breach of duty of responsible care for a patient that results in injury of the patient. So this is when you neglect to do something that you should have. You didn't give the patient their medications, and then they ended up having a severe outcome based on that. Or, you didn't provide your patient with any food or things like that. Because we want to protect ourselves and we want to prove that we did not assault our patients or engage in medical battery or negligence, documentation is super, 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 super important. Even if you didn't do all this, a patient can accuse you of assaulting them. A patient can accuse you of neglecting them. So you want to make sure that in all of your documentation, you're showing that you didn't do that. So documentation should be observations of your patient's subjective and objective physical, psychological, and social responsiveness as it relates to their mental disorder and emotional problems. You want to document every intervention implemented in the patient's response. Even if the patient refused it, you want to document that you offered it. You want to document any observations of therapeutic and side effects of medications. You want to document any evaluations of outcomes. And you always want your documentation to be geared towards the reason the patient was admitted. So a patient may need an anecdotal note or a narrative note, which is a little bit different than what you would see in a medical setting where you just kind of click boxes. You may have to do a note where you specifically write out the patient approached the nurse and was having increased anxiety. The nurse offered coping skill advice. The patient refused, demanding that they need this medication. Provider was notified and the medication was denied to the patient due to abuse in the past. Patient was then notified and offered alternative treatment. Patient refused. You do have the ability to really write out and explain the care that you provided so that you can prevent getting in trouble for any of these three things. And that's about it for the basics of psychiatric mental health care.